continue to where we left what topic we left off yesterday. So let's talk about non-biologic disease-modifying anti-rheumatic drugs. Okay, so the first one is your methotrexate. So methotrexate is an anti-metabolite, no? So the mechanism of action of methotrexate is it inhibits the folate-dependent metabolic steps, including the dihydrofolate reductase activity. So inhibiting this one will further inhibit the other folate-dependent enzymes, including your ICAR or your 5-imidazole or carboxamide ribonucleotide transformidase. So this ICAR enzyme is an important enzyme in the de novo biosynthesis of your IMP. And this will result in the accumulation of your 5-imidazole 4-carboxamide, which further inhibits your purine synthesis. So methotrexate has a central role in the treatment of arthritis, especially in children with polyarticular GIA. Now, according to studies, the response to oral methotrexate is better than response to placebo. There is no response to standard doses of methotrexate. Often do show response to higher doses, meaning to say, if you're going to increase the dose of the methotrexate beyond the standard dose, you cannot expect higher effect already. No? So those who demonstrate clinical response to methotrexate also have improvements in the growth rate, functional ability in daily tasks, and even the radiologic appearance of the joint damage. So methotrexate is well tolerated by children, and the adverse effects include GI toxicity, stomatitis, elevated liver enzymes, headache, leukopenia, interstitial pneumonitis, rash, and alopecia. And to minimize these adverse effects, methotrexate is always given with folic acid as an adjunct. Now, children receiving methotrexate should be counseled to avoid smoking, alcohol, and pregnancy. So if patients are taking methotrexate, you monitor for toxicity. So you request for CBC and liver function tests at regular intervals, initially every month for the first 3 months of the treatment. Then you adjust to every 2 to 3 months with more frequent intervals if you are adjusting the dose of or the response lead to an abnormal levels of your CBC and liver function test. The next non-biologic DMARD is your hydroxychloroquine. So last time I mentioned hydroxychloroquine as a treatment in dermatitis in patients with JDM. So we also use hydroxychloroquine as treatment in GIA, although it's infrequently used. But it's a 3 to 6 month trial of hydroxychloroquine is necessary to assess therapeutic response. And the most significant potential adverse effect of hydroxychloroquine is retinal toxicity, which results in an irreversible color blindness or loss of central vision. The next non-biologic DMARD is your Leplunamide. So this is also approved as a treatment for RA in adults, and it offers also an alternative treatment to methotrexate for treatment of GIA. So the dosing is oral and it's weight-based. And in studies, methotrexate outperformed Leplunamide for treatment of GIA in a randomized trial with a 30% response rate in methotrexate versus 68% of those receiving Leplunamide. Now, adverse reactions of Leplunamide include paresthesias, peripheral neuropathy, GI intolerance, elevated liver enzymes, hepatic failure, cytopenias, and teratogenesis. Again, avoidance of pregnancy is essential. And again, if patients are taking Leplunamide, You monitor also CBC and liver function tests every 4 weeks for the first 6 months of treatment. Then you adjust to every 2 to 3 months thereafter. Next, non-biologic DMARD is your sulfasalazine. So it's used to treat children with polyarticular GAA, oligoarticular GAA, and peripheral spondyloarthropathies. So in sulfasalazine at 50 milligram per kilogram per day dose, it achieves a greater improvement in joint inflammation, global assessment parameters, and laboratory parameters than placebo. But more than 30% of patients treated with sulfasalazine withdraw from the treatment because of the adverse effect, primarily GI irritation and skin rashes. And sulfasalazine is also associated with severe systemic hypersensitivity reactions, including your Steven-Johnson syndrome. We can also do intra-articular steroids. So you inject the steroids directly to the joint. So this is an initial treatment for children with oligoarticular GIA or when one or several affected joints have not responded to standard parenteral drug therapy in polyarticular disease. So if you do intra-articular steroids, significant improvement is seen within 3 days. And there is an anticipated response rate to knee steroid injection between 60 and 80% at 6 months. Now, when you do intra-articular administration, there are side effects. It will result to subcutaneous atrophy and hypopigmentation of the skin at the injection site. And you can see subcutaneous calcifications along the needle track. The next set of drugs that we used to treat patients with GAA are the biologic DMARDs. So the biologic response modifying drugs target specific components of the immune system. In fact, the initial biologic DMARD targeted the tumor necrosis factor A, which is a pro-inflammatory cytokine implicated in inflammatory arthritis. Now, this is a table found in your book listing the different biologics and their method of action. So, etanercept, this is injectable. It is an anti-TNF alpha. So, it inactivates your TNF alpha. And then your infliximab is also an alpha TNF, no? It's from a chimeric human mouse monoclonal antibody. Your adalimumab is an humanized IgG1 antibody that binds also your TNF alpha. Abatacept is an anti-CTL4. Your tocilizumab is an anti-interleukin 6, no? So I'm sure you're familiar with toci because of COVID. And anakinra is an anti-interleukin 1 antagonist. So these biologics can be used to patients with GAA. Unfortunately, the one that's available only here in the Philippines is etanercept, infliximab, and tocilizumab. Now, aside from giving the medical treatment, it's important to refer the patients to our PTOT friends. So, what are the reasons to refer patients to our PTOT friends? So, the physician triggers for referral include active disease, morning stiffness, if there is avoidance of activity because of pain or weakness, there is overwhelming fatigue, restrictions or asymmetric movement of any musculoskeletal area. There's a marked mood or behavior changes, especially isolation from peers, or regression of age, appropriate development behaviors, growth abnormalities, reduced school attendance or output, more than 10 days absence in the past 4 months, including medical appointments, change in the quality of sleep, and inability to do normal activities in a timely manner. So it's not just not moving a certain kind of extremity is a referral to OTPT, but even overwhelming fatigue, no? Or if there is really disturbance of the daily function because of the condition, you can refer them to for rehab. So I included this important condition because this is quite rare, but we see this in patients with systemic onset GIA. So this is called the macrophage activation syndrome. This is a rare but potentially fatal complication of systemic onset GIA. It can occur anytime, no, during the disease, be it at onset, medication change, active, or even remission during the disease course. Now, it's also referred to as secondary hemophagocytic syndrome, or your HLH. Now, there is increasing evidence that your systemic onset GIA share and your HLH share similar functional defects in the granule-dependent cytotoxic lymphocyte activity. Also, your systemic onset GIA associated MAS and HLH share genetic variants in approximately 35% of patients with systemic onset GIA. Now, this is a table in your book showing you the laboratory features and clinical features, histopathologic, and the proposed criteria for macrophage activation syndrome. So what's the prognosis of GIA in general? So children with persistent oligoarticular disease uh, oligoarticular disease fare well, with a majority achieving disease remission. So ANA positivity and with onset of arthritis earlier than 6 years of age are at risk for development of chronic uveitis. Polyarticular GIA often has a more prolonged course of active joint inflammation and requires early and aggressive therapy. So the predictors of severe and persistent disease include young age at onset, RF seropositivity or the presence of rheumatoid nodules, the presence of anti-CCP antibodies, large numbers of affected joints, and involvement of the hip, hand, and wrist. Systemic onset in children is often the most difficult to control in terms of both articular and systemic manifestations. Sorry for that noise. So, poorer prognostic factors in systemic onset GA include polyarticular distribution of the arthritis, fever lasting more than 3 months, increased inflammatory markers like platelet and ESR for more than 6 months. And remember that these patients have orthopedic complications, including leg length discrepancy and flexion contractures. And of course, the challenge mostly for us is these problems will have lifetime adjustment and employment. So it's really very important that these patients be controlled of their inflammation, no, so that they will not be debilitated later on, because they still have a long way to go. They have to continue school. They have to kanang get employed later on. So we don't want these children to be isolated from the society because of their condition. Okay, so that's the end of GIA. Before I proceed to the next topic, let's have a quick review, if you can still recall the things I said yesterday. Now, autoantibodies are common among these two types of GIA, suggesting humoral immune as the central role to the pathogenesis of this arthritis. Is it oligoarticular GIA, systemic onset, Emphasitis-related GIA, or psoriatic GIA?
Letter A, Doc.
Okay, very good. So the answer is oligoarticular. So what does a positive ANA confer in a patient with GIA? Is it patient is also positive for lupus, patient has poor outcome, patient has risk for uveitis, or patient has risk for developing systemic onset GIA?
Letter C, Doc. Risk for
Letter-
uveitis.
Okay, very good. So patient has risk for uveitis. Okay, very good. So I'll move on to the next topic. Okay, so this time I'll be talking about spondyloarthropathies. I think this is the last topic among the arthritis. So tomorrow or next week, we will start the topics on vasculitides. Okay. So spondyloarthritis is a group of overlapping disorders that share certain clinical features and genetic associations and share pathogenic mechanisms. So what are these spondyloarthritis? We have Unkillosing spondylitis, reactive arthritis, psoriatic arthritis, juvenile onset spondyloarthritis, and your undifferentiated spondyloarthritis. So spondyloarthritis is more common in adults, but all forms can present during childhood. So many children with spondyloarthritis are classified in the juvenile idiopathic arthritis categories of enthesitis-related arthritis or psoriatic arthritis. Now, this is a table showing you the overlapping characteristics of the spondyloarthritis. Um, to mention, emphasitis is more prominent in juvenile ankylosing spondylitis. Axial arthritis is not that frequent in reactive arthritis compared to other conditions. All four conditions will have peripheral arthritis. All these four are HLA-B27 positive, but HLA-B27 positivity is more seen in juvenile ankylosing spondylitis and reactive arthritis. They will not be positive for ANA except for psoriatic arthritis, and all will have a negative rheumatoid factor. All four will have eye involvement. Skin involvement is more prominent in psoriatic arthritis, and GIT involvement is more common in inflammatory bowel disease and reactive arthritis. Now, enthesitis-related arthritis accounts for 10 to 20% of GIA. So the mean onset at age 12 years old with a male predominance. It's most common. It's the most common category of GIA in India, and it can be familial as a result of the HLA-B27 because it has been found out that HLA-B27 is positive in 90% of juvenile ankylosing spondylitis and 50% of enthesitis-related arthritis. Now, approximately 20% of children with enthesitis-related arthritis will have a family history of HLA-B27 associated disease. So what are these HLA-B27 associated disease? Reactive arthritis, ankylosing spondylitis, and inflammatory bowel disease with sacroiliitis. Now, there is the susceptibility is largely genetically determined. And in fact, HLA-B27 is responsible for 2/3 of the total cases. And in addition, your HLA-B27 has this unusual property to misfold and form abnormal cell surface structures. Now, specifically in reactive arthritis, infection, be it GI or GUT, can trigger the condition. Now, this is the classification criteria for spondyloarthritis. We have the axial SPA and the peripheral SPA. So, in axial SPA, in patients, there is three or more months of having back pain, and the age of onset is less than 45 years old. There is sacroiliitis on imaging plus one or more SPA features or HLA-B27 plus two or more other SPA features. including inflammatory back pain, arthritis, enthesitis, uveitis, dactylitis, psoriasis, Crohn's disease, ulcerative colitis, good response to NSAIDs, family history of SPA, HLA-B27, and increased CRP. On the other hand, patients are diagnosed to have peripheral SPA in patients with peripheral symptoms only, and they have arthritis or enthesitis or dactylitis plus one or more SPA features like uveitis, psoriasis, Crohn's disease, ulcerative colitis, preceding infection, HLA-B27, Sacroiliitis, or two or more other SPA features like arthritis, enthesitis, dactylitis, inflammatory back pain ever, family history of SPA. Now let's go down and be detailed in the following conditions. So let's start off with enthesitis-related arthritis. So the diagnosis of enthesitis-related arthritis is seen in children if they have either arthritis and enthesitis or arthritis or enthesitis with at least two of the following: sacroiliac joint tenderness, onset of arthritis in a male older than 6 years old, anterior uveitis, or a family history of HLA-B27 associated disease like enthesitis-related arthritis, inflammatory bowel disease with sacroiliitis, reactive arthritis, and acute anterior uveitis in a first-degree relative. So initially, it is asymmetric in the first 6 months, and it involves 4 or less joints, most commonly the knees, ankles, and hips. So it typically affects the lower limbs. The risk of sacroiliac joint arthritis is highest in children who are HLA-B27 positive and an elevated CRP. So it may also present as inflammatory back pain when it involves the sacroiliac or the eggshell joints. So how do we know that we have or a person has an inflammatory type of back pain? So because I know we do experience back pain at certain points of our lives. So you know that it's an inflammatory type of back pain if the pain occurs at night with morning stiffness and there is improvement on arising. There is no improvement with rest. There is improvement with exercise. It is insidious in onset and it has a good response to NSAIDs. Next is your psoriatic arthritis. So psoriatic arthritis accounts for 5% of GAA, and the clinical features include your nail pitting, your onycholysis, and your dactylitis or the sausage digiting of your fingers or toes. So how do we diagnose? Children with psoriatic arthritis is diagnosed to have such if they have arthritis plus psoriasis, or arthritis and at least two of the following clinical features of psoriasis: dactylitis, nail pitting or onycholysis, or psoriasis in a first-degree relative. So the disease onset peaks during preschool and early adolescent years. If the onset is during preschool, the characteristics of the patients are usually female, they are ANA positive, and they have a high risk for ocular inflammation. The onset during early adolescence has an equal gender distribution, and the arthritis in psoriatic arthritis is asymmetric, affecting 4 or less joints. Next is your juvenile ankylosing spondylitis. So it begins with oligoarthritis and enthesitis, and it involves the lower extremities and often involves the hips. As compared to the adult ankylosing spondylitis, eggshell disease and inflammatory back pain are less frequent, and peripheral arthritis and enthesitis are common. So this is the modified New York criteria for AS as the diagnosis. So there should be a sufficient radiographic evidence of sacroiliitis, either grade 2 or greater, or at least grade 3 if unilateral. And patient meets at least one clinical criterion, like inflammatory back pain, limitation of motion in the lumbar spine, or there is limitation of chest expansion. So this is the Schober test that we use to check flexion of the lumbosacral spine. So How to do the Schubert test. With the patient standing, you mark the skin overlying the fifth lumbar spinous process, usually at the level of the posterior superior iliac spine or the dimple of Venus, and also measure 10 centimeters above it. So you ask the patient to do a forward flexion. So this should increase to from 2 points should increase to more than 15 centimeters. So if it's less than 15 centimeters, then you can say that there is reduced flexion of your lumbosacral spine. Okay, so because radiographic features takes longer to develop in children, criteria to identify pre-radiographic axial spondyloarthritis was developed. So this is the one I showed you earlier. Wait. Okay. So this same, no, this is the pre-radiographic features of spondyloarthritis. Okay. So the next is arthritis with inflammatory bowel disease. So in patients with this type of condition, you have to suspect if in the presence of arthritis, the following symptoms are present. Erythema nodosum, pyoderma gangrenosum. So pyoderma gangrenosum is are large painful sores or ulcers. There is the presence of oral ulcers, abdominal pain, diarrhea, fever, weight loss, and anorexia. So if naa siya ni with arthritis, then you suspect IBD. Okay, so laboratory findings wise, this condition or your spondyloarthritis in general will have an increased inflammatory markers. So increased ESR and CRP, and as I said earlier, rheumatoid factor and ANA are negative except for psoriatic arthritis, where 50% of the patients will be positive, and HLA-B27 is present in 90% of these cases. Okay, so sacroiliitis is often the earliest manifestation in spondyloarthritis. So it starts with synovitis, then it forms a myxoid marrow, then formation of the panus, then it becomes a granulation. So there is subchondral granulation. So the eroded joint margins are gradually replaced by fibrocartilage, regeneration, and ossification. So that's why in the kanang later stage of spondyloarthritis, they will have this bamboo spine. So if you look at this vertebra, no, it looks like a bamboo already. You cannot appreciate anymore the joint space, no, between the vertebra. So this is a radiographic feature seen in ankylosing spondylitis that occurs as a result of the vertebral body fusion by the marginal syndesmophytes. So it is often accompanied by fusion also of the posterior vertebral elements. So other lesions that we can see on X-ray, we have diffuse osteoporosis, erosion of vertebral bodies at the disc margin, there is squaring or barreling of the vertebra, inflammation and destruction of the disc bone border, or inflammation in the fibrocartilaginous enthesis. So enthesis is where the region where tendon, ligament, or joint capsule attaches to the bone. The gold standard for early visualization of sacroiliitis is evidence of bone marrow edema adjacent to the joint on MRI. So this is how we grade sa X-ray. So we use the Basri spine. So this is based on the lateral view of the cervical spine, C1 to C7, and the frontal and lateral view of the lumbar spine, so T12 and to S1. And the grade is 0 to 4. So grade 0 is normal, grade 1 is dubious, grade 2 is slight changes, including erosion, vertebral squaring, or sclerosis with or without syndesmophytes on 2 or less vertebra. Grade 3 is syndesmophytes, the presence of syndesmophytes in 3 or more vertebra with or without fusion involving 2 vertebrae. And grade 4 is the fusion involving 3 or more vertebrae. No, and then we also use the SAS, the Stroke Ankylosing Spondylitis Spine Score. This is the anterior and posterior changes in the lumbar spine, T12 to S1 on lateral view. So grade 0 is normal, grade 1 is erosion, sclerosis, and or squaring. Grade 2 is syndesmophytes, grade 3 is total ankylosis. So here are examples of the x-rays. So this one is the grade 1 Bastry spine, slight or dubious changes on a lateral view of the thoracolumbar region, showing slight abnormalities in the form of slight vertebral squaring. No? So there is already formation of the squaring of the vertebra. So this is compatible with grade 1. And then the early changes, so this is the frontal and lateral view of the lumbar spine, showing a bridging syndesmophyte. So this is the bridging syndesmophyte, and the slight osseous deposition at the anterior surface of the first lumbar vertebral body at the L1. So this one. And there is sclerosis, the whitish here, the whitish thing, the more white in the edge. On the edge of the vertebra is the sclerosis on the upper corner of L1. And this is compatible with grade 2 Bastry spine. We have syndesmophytes, we have osseous deposition, and your sclerosis. Okay? And then this is compatible with grade 3 Bastry spine, the frontal and lateral view of the lumbar spine, showing already the bridging syndesmophytes. So you can already see the bridge by your syndesmophytes. Okay, so this one. And the last one is the grade 4 or the ankylosis. So frontal and lateral view showing to you the fusion of the vertebral bodies, looking good like a bamboo already. So fusion na siya of the vertebra. So this is compatible with grade 4 Bastry spine. Okay, so how do we treat? So the goals of treatment include control of inflammation, minimize the pain, preserve the function, and prevent ankylosis. I have siguro in my practice, since spondyloarthritis is not so common in children, maybe I have 2 patients diagnosed with spondyloarthritis, but unfortunately these 2 patients did not follow up already. The first one I saw, I treated him for a while. He was lost to follow up, and then when he came back, he was already wheelchair bound. So you have to emphasize really the importance of follow up. So in that first case, there was really a strong family history of spondyloarthritis. The uncle also has spondyloarthritis. Okay, so the treatment regimen includes mono or a combination therapy with NSAIDs. You can give DMARDs or biologic agents. So the NSAIDs are usually used initially because it slows the progression of the structural damage. And for moderate disease, you add a DMARDs, either sulfasalazine or methotrexate. The TNF inhibitors, like your anti-interleukin 17, which is secukinumab, anti-interleukin 12, your ostakinumab, they have a kind of good response when used in adults, but their roles in children remains unclear. And aside from giving your drugs, you also refer them to and subject them to rehab therapy. Okay, so you can advise patients this one. So first, you have to advise exercise to maintain the range of motion in the back, thorax, and the affected joints, and it should be instituted early in the disease course. And you can advise them to use custom fitted insoles and heel caps, so insoles and heel caps, to manage painful emphasis around the feet. And you can advise them to use pillows to position the lower extremities when the child is in bed, to prevent pain. So I think that's the last slide of spondyloarthritis. There is pa prognosis, last slide. So, studies suggest that ongoing disease activity for more than 5 years predicts disability. And in studies, remission is seen in less than 20% 5 years after diagnosis. And the factors associated with disease progression include tarsitis, HLA-B27 positivity, hip arthritis within the first 6 months, and disease onset after 8 years of age. Okay, so this is the last slide. Before we end, let's have a quick review. So what is the test to determine the lumbosacral spine mobility? Is it New York, Schober, Wilkinson, or Bohan?
Sugar.
Okay, so the answer is Schober. Very good. Now, which of the following is a characteristic feature of inflammatory back pain? Is it pain on arising, pain relieved with movement, acute in onset, or poor response to NSAIDs?
Letter B, Doc.
Okay, very good. Pain relieved with movement. So remember, basta inflammatory, di ba, mas more painful when not in motion, and the pain is relieved with movement because of the gelling effect when patients are not moving. That's why inflammatory type of joint pains are painful in the morning, when ang gitawag na morning stiffness, and as the day passes, the pain is kanang reduced because of the movement. So the answer here is letter B, pain relief with movement. So that's it. So next week, I'll see you next week for, there is still next week, right?